Hello guys, it's me Dr. Yumna Sat and I'm back after a long gap with another new video continuing with our series of cough cluster for pediatrics. And today we are going to discuss a topic called epiglottitis. As you all know, epiglottitis is rare because of the vaccination against Haemophilus influenzae type B, and so you can imagine that it's not a very common topic for AMC. But still it can come, there's no exception. But I would say if you in exam in your AMC clinical exam, if you see any case that is relatively uncommon, so try to rule out all the possible common things first and then come to that uncommon cause, even if you are very sure about your diagnosis. So try to exclude the common causes first, because AMC is mostly giving the cases that are routinely seen in our general practice or in our hospitals, and you rarely see any topic that is not very common. But still, it's an emergency, so we need to discuss it. Let's begin. So here's a case presentation. Your case, it can present in different ways. It's one of the presentation. I'll read this for you. You are a HMO at a tertiary care hospital. 5 years old boy is brought in ED by parents with severe sore throat and difficulty in swallowing. The child looks lethargic, febrile, and sitting up leaning forwards. Now your tasks are history. Take a short history, no more than 2 minutes. Give your probable and differential diagnosis and outline management. So now if you can see that there are three aspects of this, three main tasks: history, diagnosis, and management. If there's a history of no more than 2 minutes and they've given you so much history that you can get an idea that it will be something related to an airway obstruction, that the child's having some sore throat and difficulty in swallowing. So it's something related to the back of related to your throat, and there can be an airway obstruction. So it gives you a relatively fair idea of what the scenario is. So the most important aspect in all these three tasks is to outline your management plan. They are not concerned if you give a correct diagnosis of epiglottitis. If you are very close and you give another possible cause, for example, if you say it croup or if you say it anaphylaxis, but if you are going in a proper way and if you are securing the airway, which is the key in this case, there are high chances that they will pass you. But if you give the correct diagnosis of epiglottitis, but you cannot say either because of you are running short of time, or any other reason you did not say the word that I need to secure the airway, there are high chances that you might fail this case. Okay, so let's start with the clinical features. What are the clinical features? Okay, so starting with the cause. Most importantly, it's a bacterial infection, as the name indicates. It's an inflammation of the epiglottis and most commonly caused by Haemophilus influenzae type B. It's very rare, as I told you, because of immunizations against HIP, but it's more common in those who are unimmunized. In history, the most important thing is to ask about the immunization statuses. The second thing, okay, so the presentation will be the child will be very, very, very toxic looking. It will be a toxic looking child. Remember, epiglottitis is a medical emergency, so treat it like an emergency situation. Like if you get a scenario of MI, how will you treat that? In a very quick way. So try not to spend too much time on the history, and your history and management will go side by side. So there will be high fever, systemically unwell. The voice will be muffled because why? Because there is an obstruction, upper airway obstruction. So there will be muffling of the voice. The voice will be muffled. The child will prefer not to say, will be quiet, toxic, febrile, running very high fever, drooling of saliva. There will be hyperextension of neck in an attempt to have a good airway and have a good air exchange. So it's basically a compensatory mechanism. Dysphagia, definitely, again, because of swelling at the back of your throat. Pooling of secretions, drooling of saliva, and there will be absent cough. because there is an upper airway obstruction, so the cough reflex is suppressed, and cough will be either very low, or a cough will be absent, and there will be a low-pitched expiratory stridor. So all these findings I have copy pasted from RCH, so you can have a look from there. So these are the important things that you should know that can happen in a case of epiglottitis. The child will prefer to sit upright, leaning a bit forward. The typical position is called a tripod position. I'll show you the image here in the coming slide. Remember the 4 Ds of epiglottitis. So it's good to have some mnemonics for every case, so that if you are completely blank in any scenario, you at least utter some words. So 4 Ds are distress, drooling, dysphagia, and dysphonia. Distress, so definitely the child will be in very much distress, very toxic looking child. There will be drooling of saliva, and the child is sitting in a tripod position. Hyperextended neck, there will be dysphagia, difficulty in swallowing, and dysphonia, difficulty in talking. So the child will not be talking to you, will be quiet. And the most important thing is, it is a medical emergency. So if you get a case, so from outside your station, if you get an idea that it can be a case of epiglottitis, so try to start outlining your management plan together with the history. Do not spend too much time excluding all the causes, because as I told you that I'm covering it in a cough cluster, but there's no need to ask all the cough questions, because you will lose your time, and you cannot focus much on the management, which is basically the main task here. Okay, in history, first of all, I'm emphasizing, I know because you all will be in the exam, we all want to be the best. But what my advice is to try to be focused, try to calm your nerves, and focus on what they are asking, what they want from you. So do not delay them. If it's an emergency situation, so compare it with an MI. If I give you a scenario of MI, everyone is going to start to say that, okay, I'll take the history, but I'll take the patient to the resuscitation bay, and so on. You know how to follow a case of MI. It's a very common scenario. So it's also a medical emergency, epiglottitis. You need to take some history, but if you are suspecting that there is an upper airway obstruction, so please do not delay the management of the child while taking a prolonged history, excluding all the possible causes of cough and sore throat and fever. So be very vigilant. History of cough, history of fever, sore throat, and immunization status. These 4 things are very important. Cough, okay. So as I told, in this scenario, the patient has this, as I told you, there will be either there will be no cough, or there will be very low pitched cough. There will be very soft cough because of the obstruction in the upper airway. So there will be fever. Fever will be very high grade. The child will appear toxic to you. So there's no question in that. Sore throat, yes. Sore throat is very important. So you can ask, okay, since when? General questions, that since when is the child having this? Since when is the child having symptom? The next important thing is immunization status. That is the child fully immunized against all the childhood immunizations, because he's a 5-year-old child. He should be immunized completely by now. So ask about the immunization status. Ask about if there's any sick contact, and then ask about to rule out other differentials or upper airway obstruction, which include anaphylaxis. Is the child allergic to something, any food or any other allergen? Ask, rule out anaphylaxis, rule out a foreign body, although uncommon here at this age, at the age of 5 years. But again, is there any chance of inhalation of any foreign bodies? Was the child left unattended? What was the child doing when you noticed this sort of all these symptoms? So, but in case it will not be this much toxic in case of inhaled foreign body, and there will be usually they are unilateral chest findings. Okay, now, and there will be cough, and there can be some vomiting. So there are other things that can differentiate inhaled foreign body from epiglottitis. Other things are bacterial tracheitis. It's also inflammation of the trachea. So, but it will be tender over the trachea. So these are the common things that there, and also there is a possibility of peritonsillar abscess, which you all are aware about. That's quinsy. That it is because of the swelling at the back of the in the peritonsillar area that causes sore throat and dysphagia. They will be common, but drooling of saliva and sitting in a tripod position, upper airway obstruction, they are all and immunization status. So they are all targeting towards epiglottitis. Again, as I said, it's not necessary that you give the correct diagnosis of epiglottitis, but it's necessary that you pick up that there's some upper airway obstruction. So here's a position that shows you that the child is sitting on the bench, leaning a bit forward with a hyperextended neck in an attempt to have a good air exchange. But as it's because of the swelling, you can see that there is swollen epiglottis that's obstructing the airway. Okay, so diagnosis. Investigations should be deferred until the airway is secure. So the most important thing is epiglottitis, secure the airway. Epiglottitis, secure the airway. So first, when you suspect, if you have taken the history, you are very sure that it can be epiglottitis, involve the seniors first. Involve some, because you are a HMO, you cannot do anything. You have taken the history, you have diagnosed it, it's really good. Now you have to do it in a multidisciplinary team. So make sure that the airway is secure. Do not try to auscultate with the child, or do not try to do a throat examination, because it may agitate the child. It can worsen the airway obstruction. So what the first thing you should do is, once you have taken the history, you should start, if you're very sure, so you can say, you can start interpreting it to the parents that, look, I have taken the history, and based on the and the findings that you have told me, I do not want to disturb the child. I will definitely have a look on him and we will examine him, but I think there is some obstruction in the upper airway and it can be fatal. So we need to secure the airway, and I am involving my seniors. I have consulted my senior clinician, my anesthetist and ENT. They will be here shortly, and once the airway is secured, we will start a definitive management plan. So what is diagnosis? And once the airway is secured, then we'll do some investigations that will include X-ray of the neck, or the soft tissues, or soft tissue of the neck, X-ray of the chest, sorry, or soft tissue of the neck, or CT scan. The X-ray will show you a thumb printing sign, which is basically the swelling of the epiglottis. It's not relevant to your case, okay? You do not need to tell so much detail. So you'll tell that after securing the airway, because I'm concerned about the child's breathing. Once I am sure that he is breathing all right, airway secure, we will do some X-ray, or if needed, CT scan, and we will do the definitive tray, and we will then manage him accordingly. Definitely the parent will be upset. Counsel the parent, make them sorry. Okay, so make them comfortable that you have diagnosed it, and although it's a serious condition, but it is manageable, and we will work in a multidisciplinary team to make sure that the child gets the proper treatment at the proper time. Okay, so I've discussed everything. The diagnosis is basically, you have taken the history. Based on history, you can diagnose it. Once you have secured the airway, you can do the investigations that include the chest X-ray, or X-ray of the soft tissue of neck, and CT scan. Okay, so here's the X-ray that shows, you can see the air is pointing the thumb printing sign, but it's enough. If you even remember that epiglottitis shows a thumb printing sign on its lateral chest X-ray, that's enough. X-ray of the neck, that's enough. Now, as I already discussed, the differential diagnosis. The differential diagnosis of epiglottitis does not include all the differentials of cough, but it includes all the differentials of acute upper airway obstruction. That will include croup, anaphylaxis, inhaled foreign body, peritonsillar abscess, bacterial tracheitis, and trauma. All these have some clinical features that differ from those of epiglottitis. So you can differ all these things in history. So if you have started taking the history, okay, so for suppose if you're in the history, ask, okay, what's the parent, whatever the parent name is, so to ask them, okay, I do understand he looks very very ill, he looks like he's very lethargic. Can I know what exactly happened? Can you tell me a bit more about it? So start like this and let them speak, because they'll tell you everything. But if they've given you 2 minutes time in history, they will tell you everything. So let them speak first. Once they have told you everything, then there are only one or two things that you need to answer, ask. So ask about any foreign chance of any foreign body inhalation, any allergies, previous allergies to any food or any other allergens. Is there any in croup there will be a barking type of cough. So definitely that's a very different distinguishing feature. There will be no cough or very low cough in epiglottitis. Again, in peritonsillar abscess, there will be a sore throat for a long time, and sometimes there are repeated sore throat infections. So they can give you that, and it's not as peritonsillar abscess. It's not as severe as epiglottitis, although it can become, but usually, yeah, it does not. It's less severe as compared to epiglottitis. Now, bacterial tracheitis, the symptoms are more or less similar, but it's tender over the trachea. So it's not a big deal if you say bacterial tracheitis instead of epiglottitis, because you are just diagnosing it on the basis of history. You don't know anything else. And the next thing is trauma. So you can just ask in one question, is there any chance of trauma to the throat? Yeah, that's it. Here's the next one. Okay, so now comes to management. As we have already discussed that it's a medical emergency. So and remember that you are a HMO. In AMC, either you are a HMO or you are a GP, not any other that. So know your limits. You cannot manage all the cases on your own. You need to involve your senior. You need to involve the relevant departments. In this case, your senior clinician. If you are in peds, so your pediatrician, the anesthetist, and ENT specialist. Secure the airway, which is mainly by endotracheal intubation. So first thing in epiglottitis or any other acute upper airway obstruction is securing the airway. The definitive treatment is, once you have secured the airway, start with maintain IV lines, then we'll start with hydration and blah blah blah, and we have done that. And then the definitive treatment is, because it is caused by a bacterial infection, mainly Haemophilus influenzae type B, so the definitive treatment is intravenous antibiotics for 5 days, that is ceftriaxone. So now you can say that I'll tell you after finishing the slide, I'll tell you that how to outline your management plan to the parent while awaiting the other definitive measures, because as I told you, you cannot directly jump on to the antibiotics, you cannot directly jump on to other things before you secure the airway. So if meanwhile, while you are waiting for other things, you can use oxygen to help improve the saturation, but it does not relieve the obstruction. Obviously, it's because of swelling, so oxygen cannot do anything else. It can only make a bit better at the oxygen saturation a bit better. Consider nebulized adrenaline to provide temporary relief in any life-threatening. So if you are not sure that it's epiglottitis or any other cause, so you are treating it as general, a broad term, that is acute upper airway obstruction. And in any acute upper airway obstruction, be it because of a foreign body or any other thing, or even a croup, you need to give nebulized adrenaline to give a temporary relief. And also consider giving a steroid to reduce the swelling. It reduces swelling. So these three things are just temporary measures till you secure the airway, until you give a definitive management, that is the antibiotics. So start outlining the management plan. If we do okay, so starting with hello Mary, my name is Dr. Yumna. I've just read the case of whatever the name of the boy was, suppose John, and I came to know that he's having some sore throat and whatever it was, a sore throat and fever, and difficulty in swallowing. Can you tell me a bit more about it? So she'll tell you, the mother or the father, they'll tell you everything. Okay, the doctor, it started like this and that, and he was having some fever and sore throat, and then he looked very ill, and he's sitting, he's not talking, his voice is, and blah blah blah. And they'll start crying, because definitely the child is in distress. You need to counsel the parent as well. Mary, I do understand that you are very disturbed, and you can say that, being a mother or being a father, I can imagine seeing your child in such a situation. It's really distressing for you, but if you can help me in telling the details, we will together work out on outlining the management, and I'm sure that I'm quite hopeful that we are going to manage this case very well, and it's very good that you have brought him very early. So can you tell us, so just when you gather enough information, and if you are sure about epiglottitis, you can say that. If you are not sure, you can say that I'm suspecting that he is having an obstruction in the upper airway. Or if you are very sure of epiglottitis, so say then, maybe I'm suspecting that he, based on the history, look, I do not want to, I can do an examination, but in this case, I'm suspecting he is having obstruction in the upper part of the airway, and I do not want to disturb the John. If he's sitting in this position and he's comfortable, I will let him sit in this position and make sure he's comfortable. I do not want to agitate him, which will make the condition worse. I believe he's having a condition that's called epiglottitis, which is basically an inflammation of epiglottis. It's a flat tissue-like flap on the back of the throat, and the function of epiglottis is to cover the windpipe while we are swallowing. And but just when we have finished swallowing, it again open up and letting the air in and out. So because it's at the back of the throat and this part is swollen, so it makes the airway obstructed, and that is making him difficulty to breathe, and that is the reason also that he's having some muffled voice and difficulty in swallowing. Are you following me? Look, Mary, I don't want to scare you, but it's good that you have brought him here early. It's good, but if it's not treated, it can be fatal. It can be fatal. It's a medical emergency. I need to involve my seniors. I've already done that. I've already sent a call to my senior pediatrician, my consultant, and also the ENT specialist and anesthetist. They'll be here soon, and we'll start by. Meanwhile, what I'm going to do is I'll attach some oxygen. Oxygen is not going to help him anyway except for bringing up his oxygen saturation, because there is some obstruction, so oxygen cannot relieve the obstruction. It will only give him a temporary relief. It will only bring the saturation up. The next thing I'm going to do is I'm going to give some nebulized medication called nebulized adrenaline, which will give some temporary relief. Till then, we start doing some definitive management, and also I'm going to give some steroid to reduce the swelling. And our first priority is to secure the airway, because we are concerned. I'm very concerned about the airway. I know that it is caused by bacteria and hits the inflammation, but the swelling will not go immediately. It will take some time. So the first thing is to, are you following me, Mary? Okay. So first thing is to secure the airway. And once we are sure that the airway is secured, and then we'll start management accordingly. So because as I told you, it's a bacterial infection, we need to give some antibiotics, and it is a manageable condition, and we are quite hopeful that this recovery will be very good. He'll be here till we are sure that he is doing fine and there is no edema or swelling of the upper airway. And once he is you can take him, once he is feeling better, you can take him home and make sure, and if the child is not immunized, it's better, I strongly suggest you to get him immunized against Haemophilus influenzae type B, as we have included, because in the it is included in the immunization, because this epiglottitis is a vaccine preventable disease. This is the way that you are going to counsel the mother, tell the mother your management plan, be very empathetic, and tell whatever is in your mind. Again and again, I tell you, it's not necessary that you reach perfect diagnosis, but it's necessary that you understand that it is a case of an upper airway obstruction, and you need to secure the airway. You need to intubate the child if there's severe obstruction, and then you are going to go for the definitive management, whatever the case is. I hope this video is helpful for you. If you have any queries related to it or anything other than it, you can feel free to ask me. Have a good day, and bye-bye.